So I'd like to welcome today Professor Stefano Nava, who's a pulmonologist and an intensivist and the Director of Complex Structure and Pneumology at the Hospital Santa Ursula in Bologna. Thank you very much for spending the time talking to me today about COVID. So in order just to get a picture of how things have been for you, would you mind just describing the institution you work in and how you have been working at the moment?
Okay, thank you, Michelle. You spell and you say correctly the name of my hospital, that is very good for you. Yes, I work in a busy unit. Since March last year, we were working only for the treatment of COVID-19 patients. We got a total of 32 COVID beds for the treatment of acute respiratory failure due to pneumonia and COVID. So we are a very busy unit. Unfortunately, we needed to shut down most of our outpatient clinic because our building is fully devoted to COVID, and for safety, we do not allow the outpatient to come to our building. So we reserve just a small space in another building for outpatient clinic for a very limited number of patients.
And I know that you were hit particularly badly at the start of the pandemic this time last year.
Yeah.
What were the key things that you learned from the first wave?
From the emotional point of view, we learn how to work as a team. This was the main issue, I think. We really stay united, as the Americans say, united we stand, but I think it's the best way to face a disaster, a tsunami like the pandemics was and still is. And we really strengthened our relationship, not only as a doctors and nurses, but also as a team, rowing all together in the same direction. This is the first thing that we learned. The second thing is that apparently we were too much aggressive, I would say, during the first wave. We really base our choice, for example, of instituting invasive or non-invasive mechanical ventilation mainly based on PF ratio, PaO2, FaO2 ratio, and considering this patient as, I would say, IRDS patient or de novo respiratory failure. And we learned with time that sometimes with this particular kind of acute respiratory failure, you do not really need so aggressive as we were in the past. So two big lessons, the working as a team and now being a little bit less aggressive as we were before.
Yeah, I'm sure it was a steep learning curve because as we're experiencing now, the flood of patients was very quick for you. I think an important point might be, are the type of patients that you're seeing this time round at the moment different to what you saw initially?
Well, we are trying to understand. So it is, I think, a little bit too early to really understand the difference between the first and the second wave. For sure, especially at the beginning of the second wave, we face a burden of younger patients than during the first wave. I would say that in March last year, our more or less average of patient was around between 75 and 80. And in October, when the second waves badly start, initially we have an average age of around 45, 50 years old, so much younger. And then with time course of the second wave, the age increased, but never reaching the high age as we saw during the first wave. Probably this is related to the fact But older people now are much more cautious about the disease. They stay at home. They got anti-flu shots or whatever. They don't go out as they were used to do. So these are the main reasons. And the second thing that probably is different is that we learn how to deal with the patient even as outpatient. I mean, patient in primary care. Most of the disease are intercepted much earlier than during the first wave. So the GPs, they test the patient right away as they show symptoms. They give to the patient advice. We gave actually the saturimeter to almost all the people with fever and symptoms likely to be due to COVID. We use rapid assessment for the presence of COVID disease. So altogether, we manage much better the patient than during the first wave. So now we admit really patients who need care in the hospital. During the first wave, the hospitals were overloaded because we didn't know which patient to admit or not. Now, a lot of patients, they can stay home. They have this, if they test positive and they can't stay at home for different reasons because the house is too small, they live alone or whatever, we have special facilities. Some of them are hotels. They are called COVID hotels, even 4-star hotels, where they stay when they're not sick enough to deserve hospital admission. So this was the main difference between the first and the second wave.
And with regards to the treatments that you're offering, would they be different now between the first wave and the second wave? Is there a difference between ages over who would be offered, for example, ECMO versus intubation and ventilation versus non-invasive ventilation? Do you have a protocolized, strategized way of doing that, or is it very much patient dependent? Because obviously there are other factors that are involved in decision making, of course.
I will split this interesting question in two: ventilatory support and pharmaceutical and drug treatment. There are two different issues, I think. They may join together, but they're different issues. Concerning the support for respiratory failure, as I said, we were less aggressive, very few patients on ECMO, less percentage of patients being intubated. At the beginning of the first wave, we used a lot of helmet CPAP. Well, this was mainly due to the fact that we were not prepared. We didn't have many NIV ventilators. I mean, not necessarily my unit, but all over the country, and very few high-flow nasal cannula devices. So I would say that around 70% of the patient needing respiratory support, if we exclude intubation, were on helmet CPAP. Now they are almost evenly distributed within NIV, high-flow nasal cannula, and helmet CPAP, while this was not the case during the first wave. The problem also that we face, however, especially in the first wave, using a lot of helmet CPAP and few NIV, was the fact that some hospitals, they run out of oxygen very quickly. Because with high flow nasal cannula and CPAP, you need a lot, as you know, you need a very high oxygen flow. So the hospital were not prepared to consume a so high level of oxygen. We also learned that some of the patients can be successfully treated even with quite severe PF ratio with standard oxygen. As I said already 2 times, we learned that at least at the beginning, we try before going to NIV, iFlow, or CPAP, we start to give them reservoir mask, Venturi mask, and I think 50% of them, maybe a little bit less, they can be managed with oxygen alone. As a matter of fact, out of our 300 patients during the second wave, 25% of them, they were receiving only oxygen. Do you want me to give you a PF number? Our average pH at that mission was 147. Still, 25% were satisfactorily managed only with oxygen. Concerning drug treatment, I think that in line with what you British show, with the recovery trial, we really use a lot of steroids. To be honest, against all odds, I start using steroids. We start using steroids during the first wave. Most of the people were complaining. They said, why you give steroids? I mean, steroids may increase replication of virus. But if you provide this therapy in the right time frame, that means not in the pro-inflammatory phase, but during the inflammatory case, I would say between 5 and 7 days after the onset of symptoms, as has been demonstrated in sicker patients, then steroid may really make the difference. Antivirals, all the other drugs, well, you know the literature, there are not like robust data as we have for steroids.
Yeah. I know that one of the concerns has been around when we look at ventilators, portable ventilators, we're not talking about the ICU ventilator here, about whether some of the less sophisticated ones, whether the motors and the blowers are suitable for COVID patients. What's your experience been? Is it been that you've been using the higher end ones when you've needed to, or that you've used a mixture of both and you've had an equal success rate or been unsuccessful?
Michelle, we have 7 respiratory intensive care beds, and as I told you, 27 sub-intensive care beds. Well, during these last pandemics, we only had the high standard ICU ventilator in 7 beds. All the other, for the same severity patient, are treated when needed with, I would say, intermediate care ventilators, like the Vivo 40, Vivo 50, whatever is available. And so we apply extensively NIV in this patient using, if I may use this word, because with portable ventilator, because most of the people, they think that there's more, this ventilator are a sort of toys compared to ICU vents. Well, I know that here we are in the Brea's house, but I have to be quite open and honest, and I invite people to come here and to see that we rarely use ICU ventilators. In these pandemics, we use a lot of portable ventilator, and you don't need sophisticated mode. It's pretty simple to apply ventilation in this patient. Sometimes they look a little bit by RDS, but they're not. The pathophysiology is not necessarily the RDS.
Yeah, no, I mean, we utilised, we had a different setup, but we definitely utilised the portable ventilators for weaning, especially to decrease ICU stay. So, yeah, fantastic.
We use, Michelle, we used to treat the patient. I mean, and weaning, I don't think is a major problem. When you extubate the patient, I don't think is a major problem weaning for COVID-19 patient. I think it's pretty easy to wean this patient off.
They're surprisingly quick sometimes. You think that they're going to take longer and they surprise you.
Absolutely. And during the first wave, I remember that you wrote me a mail concerning the problem of secretion. Well, I don't know if Italy is different from UK, but we face very, very few cases of problematic secretion removal. Usually it's pretty straightforward during intubation and or NIV, whatever, and at the time of extubation. Very few cases of thick secretion as reported by others.
Yeah. No, I agree. I think one really interesting thing that I've seen and heard happening much more in this wave, whichever one we're in, is the utilization of non-invasive aids, so non-invasive ventilation, high flow therapy, and self-proning. So in the non-intubated patient, much more than what was in the first wave. And surprisingly, I've found that there's been very quick improvement in individuals. How have you found it? Or are you utilizing this technique, or are you just keeping it to the intubated and ventilated patients?
No, I mean, concerning the non-invasive support, we have published probably the largest study so ever, almost 700 patients outside the ICU, employing one of the three kind of support: high flow nasal cannula, CPAP, and an IV. We got an intubation rate less than 30% and mortality rate less than 30%. This was quite surprising to me, because the average PF ratio was around 150 in this patient, that it was exactly the same of the Italian paper published on JAMA early in March last year, where the average PF in the ICU in Lombardia, the larger Italian region, was exactly 150. So for the same pH, we could successfully ventilate non-invasively this patient outside the ICU. Well, you may claim, how did you record the PF? One thing is recording PF during invasive ventilation, when you can apply, for example, very high PPAP, whatever. But I mean, the severity of the patient may be not really comparable, but still very sick patient. Remember, the lung safe study clearly show that if your patient has a PF below 150, you need to intubate this patient. Actually, during this pandemic, we were able to ventilate exactly this kind of patient with very successful higher rate of success. Concerning proning is an interesting issue. We are now performing a study. We use a lot of proning. The physiology of proning is well known. You improve ventilation perfusion ratio, you avoid over-distended alveoli in the ventral part, and you decrease the collapse alveoli when you move a patient from supine to prone. You have cardiovascular effects. So there are absolutely irrational to apply this technique. Not all the patients are responded well, and not all the patients are really, I would say, compliant to this kind of approach. Some of them, they got scared. Some of them, they can't prone themselves. Sometimes it's not easy when you wear a helmet or a full face mask, even high flow. So appealing technique, but not always easy to apply.
I think you've got so many tips. We could talk for hours today. If there was a key thing that you wanted to get across to people with regards to learning or tips or what to do with these patients, what would it be? I'm totally getting that we're treating more patients at home, so we've changed our models of care, we're utilising more non-invasive aids and techniques and managing these patients outside the ICU with really good success rates, and that drug therapy has significantly improved prognosis. So I think outside of that, is there any key tips that you would want to give us, whether that's with regards to non-invasive aids, drug therapy, what we should be looking for, if it's something that you often see with patients that we need to be aware of, that we can really sort of hone down and improve our clinical practice, because that's the key thing in these group of patients.
Okay, I would say 3 clinical tips. The first one, never think that the patient is improving. Some patients, they come to the hospitals with quite satisfactory arterial blood gases, good sensorium, no dyspnea, but after few days they can suddenly worsen. Still, we did not really understand what is going on in this subset of patients, but some patients, they come with, let's say, single organ failure, like the lung, 200, 250 of PF ratio, no dyspnea at all, and after 3 days in the hospital, boom, they collapse suddenly. This is one side of the coin. The other side of the coin is never give up with non-invasive technique when the patient does not improve. I think the huge difference is that when you have an IRDS patient, you should be very quick in switching from NIV to intubation. They say 2 hours, 3 hours, whatever. I mean, depending on your experience, but you need to be quite fast in pick up when the patient is not improving. During this pandemic, and do not ask me why, we need to learn why, you can give the patient to 2-3 days with stable, even low PF ratio, and at the end of the day, one morning you come to the hospital and the patient abruptly change. So there is something still mysterious, but never give up if with NIV, if the patient does not improve. The patient collapse is another issue. And then the other confusing thing is dyspnea, because dyspnea is a major determinant of intubation, for example, and as repeatedly, I don't say demonstrate, but suggested, a subset of these patients, they come to the hospital and they read the newspaper and they said, why am I here? I'm feeling fine. And they are black, you know, they had 40 millimeters of mercury of oxygen breathing room air. And you say, well, you are sick. So why do you need this oxygen? I don't need it. Last but not least, safety issue. I still see a lot of people with a huge concern about the use of these aerosol generating devices. Well, there are tons of literature showing that 4 liters of oxygen with the nasal prongs are worse than a good CPAP, NIV, or high flow nasal cannula. You need to choose the right interface, obviously. You need to put the filter where in the correct fashion. But then if you know that you enter in a room with a COVID patient, so you also protect yourself. I make my final conclusion as a patient also. I got sick very early, and 2 nurses, they got sick. We are almost 100 people working in my unit between doctors and nurses. So 3, I would say, casualties out of 100 people. And me and the chief of the nurse, I'm 100% sure that we got sick because we attended together the evening meeting every night at 7 p.m. outside the unit in a room with all our colleagues, drinking coffee. Some of the people were not wearing masks, stating, well, I mean, here we are all doctors and nurses, so who cares? And the other nurse got the husband that was sick before she did. So I'm pretty positive that if you apply this aerosol generating device, but you protect yourself well, the chances of getting the disease is very small. I think it's higher when you walk outside, when you go in the tube in London or in the bus here in Bologna. Since it's a small city, we don't have underground, obviously.
No, I agree that, and purposely, not purposely, but you don't wash your hands, you touch your phone touches your face, you show someone your phone, they touch it. There are so many other ways, and I think we have definitely learned that good PPE is the key, and does keep you safe from aerosol generating procedures.
Absolutely, absolutely.
I think it was really interesting what you said about patients on non-invasive aids, in that you can leave them for a while, as long as they're not deteriorating, because this is something that's not necessarily in our mindset. Often you start off with oxygen, and if they're not improving very quickly, you're changing oxygen to high flow therapy, and then you change that to CPAP therapy, and then you may move to non-invasive ventilation. And if from what you're saying, that's just not necessarily the case.
Yeah, I mean, the problem is, as you know, one of the main risks is ventilator-induced lung injury or self-induced lung injury, depending of how do you consider things during an assisted mode of ventilation. The trick is not the patient allowed to really breathe too hard, because transpulmonary pressure, as you know, is a sum between what you set on the vent, PAV, airway pressure, whatever you want to call, and the effort generated by the patient muscle. So if you see that the patient is really struggling and making a really hard effort, then you can speculate that transpulmonary pressure increased dramatically. So in this patient, you need to be very, very careful, because you can deteriorate even more the alveoli damage. On the other side, you have a very powerful weapon, that is sedation of this patient. You can judicially sedate the patient to decrease their work breathing. However, as I said, some patients, they don't feel any dyspnea. So they are the ideal candidate for NIV, because they generate a relatively small pressure with their inspiratory muscle. So the risk of lung injury, in my view, could be quite small. Second point that I think still is important, and I forgot to mention before, is that we use a lot, you know, that there is a concerning the interface, there is the rotating, I would say, strategy, right? To change between nasal, full face, total face, whatever. We rotate the devices, especially NIV and high flow nasal cannula. As you know, most of the people, they can't stand 24 hours on NIV, so we alternate high flow with NIV. And I think this is quite successful. And so you can even bargain with the patient, you know. So it's this pandemic really taught us that combining two different kinds of support, as we do for masks, may be an interesting strategy for the future even.
And just finally then, do you think that there needs to be a specific ventilator designed for COVID patients from anyone, or are the tools that we've got out there enough to cover what's needed?
are more than enough. As I told you before, we don't need the sophisticated ventilator and sophisticated modes. We were really, honestly, very successful using portable devices, provided you can set also oxygen, I mean. But I don't really think that these patients, they need fancy modes. I mean, they're relatively simple to be ventilated.
Did you ever utilize putting the oxygen into the circuit nearer the mask so that you're delivering higher oxygen concentrations to the patient rather than through the back or further away?
Yeah, we did it, depending. You know, we use a lot of different brand of ventilators, depending which ventilator are we using. But, yes, we did. We supply oxygen with the, I would say, the port close to the interface, obviously.
Yeah, I was just sort of thinking about a lot of hospitals, particularly you've seen them reported even in this wave running out of oxygen. So obviously trying to get the most to the patient, giving the least amount in order to help prevent oxygen debt.
Right.
So if, for example, your hospital was under stress and you would normally put it into the back of the machine, one strategy would be to move it, but obviously it can affect the performance of the ventilator being in the circuit rather than where it's supposed to be.
Right. Right. No, absolutely. Absolutely. What else can I say? Remember that we are, I don't want to play the devil advocate, but we analyze data in these hospitals, and still in the general ICU, I see patients with 150 millimeter of mercury of PaO2. I want to remind to all the people that we don't need to reach 99% of oxygen saturation. We can spare oxygen, basically be very happy with a saturation between 92 and 95, I would say. You don't need to reach 99.99% of saturation. So you can save oxygen, really. I'm sick and tired to see patients when we are called as a consultant in the general ICU having more than 150 of PaO2. It's not natural. Do you have 150 millimeter of mercury now that you are talking with me? I don't think so. I mean.
No, I think everyone wants to be a high achiever. So we all aim for 99, 100%, but really we don't need to be.
Absolutely, absolutely.
I'd like to thank you so much for spending the time talking to me today. It's been an absolute pleasure and a total insight. And every time I listen to you, I pick up so many tips that are so clinically relevant. So thank you so much.
Thank you so much, Michelle. Thanks, Breas, for inviting me to this interesting talk, I would say. It's always nice to share our real life experience with colleagues all over the world. Thank you again.
Fabulous.